Okay, shall we start? Okay. Good afternoon. I'm Amit Tiwari. I'm a GP, but I also spent some time at NHS England as a medical advisor. I'm a training program director for Colchester, and this is Sunita. She's one of the trainers locally in Basildon, and we're here to talk to you about performers list appraisal and revalidation. So, can you just show of hands? Are you all ST3s? Is anybody here not an ST3? What do you do? You've just finished. Okay, perfect. Are you on performers list? Are you on the performers list? Good. Okay, fine. So I'll take you through performers list. Sunita will talk about appraisal, and then I'll come back to revalidation. Okay. Where are you guys vaguely in ST3? Who's finishing in August? 1, 2, yeah. And the rest of you are a little bit further behind, I presume. Yeah. Okay. Let's start then. So, anybody have any ideas how to get on a performers list? No. Okay. So you can apply to join the performers list as soon as you have your outcome 6 from your final ARCP panel. And I think that the moment you get your outcome 6, please get on the website and start the process. Okay. It's a fairly long process, but there's a lot of information available on their website. Okay. So outcome 6. The same evening, you're going to go onto the website and you're going to start filling in the forms, okay? Is there anybody here who's not local? There's nobody here from the international recruitment program. You are?
I'm on a visa.
You're on a visa? Okay, fine. So that shouldn't really be a problem. Yeah, so you can get on this irrespective of that. When it comes to working, somebody's going to have to sponsor you in some form, but you can have that conversation separately. Okay, so essentially there's 6 steps to applying. The first step, go on here. There's about an 8-page form that you have to fill in. Really straightforward: name, GMC number, dates of births, hospital experience, and they want some up-to-date information. So you need your DBS check in the last 3 years. If you're an HE trainee, you should have that somewhere. Make sure you have access to it. You need email addresses. They won't accept addresses or surgery names. They want email addresses. If you don't have email addresses, they will reject it and send it straight back to you. Okay? So 2 references and their email addresses. It's polite to ask your previous trainer, do you mind if I put you down as a reference, so there's no big shocks coming up, or anybody else you want to use, okay? You need, for your outcome 6, you need an up-to-date BLS and safeguarding level 3 certificate as well. You should all have that. You have to reflect on it in your, for your final ARCP, and it should be within the BLS should be within the last year. Safeguarding level 3 should be in the last 3 years, okay? Are you all happy with that? Does that all make sense? Yes.
DBS check.
Yeah.
How recent does that have to be?
So if you're an HE trainee, you would have had one when you joined, okay? And it's an ongoing, continuous one while you're working anyway, so you shouldn't have too much problem. I would write to somebody in the deanery and say, can I have my most recent up-to-date one? Yeah. Okay? It's harder for people who haven't worked for a while because they do have to go through the police, and there is a 10 to 12 week delay even just to get a DBS check, which is a bit of a nightmare. Yes? Yep. This is one of the bizarre things about performers list, okay? So to be a GP, you need an up-to-date BLS certificate. An ALS is valid for 3 years, but it doesn't count, bizarrely. So you need to get yourself onto a local BLS course. The private hospitals do it for free. Most training schemes offer it at some point or another. If you're in a GP surgery, every year they will have a rolling BLS update for all the staff and GPs. Just get onto one. It's not difficult. It is a quirk, and when we go into appraisal and revalidation, you find it's exactly the same problem. ALS valid for 3 years, it doesn't count. You need a yearly BLS and anaphylaxis and defibrillator training certificate on a yearly basis. Okay? So there's your form. So 12 weeks from start to finish, which is why as soon as you get your ARCP outcome 6, get on and do it. Okay? They're very quick at rejecting forms. So make sure it's filled in properly, check it, double check it. So to submit the application, that's your email address. So when you go on the website, it's all there. That's the email address. And you're meant to write your email address and your name and NPL1 in the email subject line so it goes to the right person, okay? You should get an email back saying, we've got your application and we will be looking at it, okay? So the PCSE will go through it with a fine-tooth comb, making sure all the information is present. And when if there is anything missing, you'll be contacted hopefully quite quickly to say we're missing this, that, or the other. The last person I know who did it didn't put in email addresses, and it came straight back to him. And every time you resubmit, the process starts again. Okay, so your 12-week clock just keeps resetting. So try and avoid that. When everything is ticked off and that's clear, they will call you for a face-to-face meeting, okay? I don't know where our local office is. I know there is one in London near Tottenham Court Road that people have to go to. And when they call you, they will give you a list of information they want you to bring along for the meeting. The last one I saw, they wanted passports, certificates from your primary qualifications, as well as sort of your CCT, but they'll give you a list and a bunch of dates that you can talk to them with. Email back and forth. They're quite good at answering emails. They're not very good at answering phone calls. And if you send a letter, good luck to you. So step 5, once they've got all the information, they will then start to process all the information. Once everything is done, that information then goes to our local offices. So if you're in Essex, all the information will go to the medical directorate in Swift House in Chelmsford, which is where our local team is for all of us. And then once they've processed your things, tick the box, seen your certificates, make sure you're up to date and ready to be a GP, they'll send the decision back to PCSE, who will email you and say, you're good to go, okay? You can check, so if you Google performers list Essex, it will take you to our website. You can stick in any GP's name and it will tell you if they're on the performers list or not and where they're on the performers list. And normally it actually tells you where they work as well, okay? So once that's there, you're ready to go. That's it. Once you're on the performers list, you're free to work anywhere in Essex or actually in the UK for that matter. When you apply for locum jobs or any jobs of any sort, most GP surgeries will go onto the performers list and make sure you're on there. You can't work anywhere without it. There have been PCSE in the last year and a half have been a little bit slow. I know from the last batch of GPs that qualified, some of them did have to sit around for 6, 8, 10 weeks before all this was processed. So time really is of the essence, so don't leave it too late. As soon as you have a letter of confirmation, get on, and then you can be a proper GP. It is quite a rewarding job, even though it is hard work. And yeah, once you get there, good luck. If you want to talk about jobs, there's plenty of people around to talk about the next steps there. Okay, I'll hand over to Sunita, who's going to talk to you about appraisal and revalidation.
Some of you know me here. So I work here. I'm local, unlike Amit. So I just work in Wickford. I'm a GP trainer, and also I'm the senior appraiser as well. So I kind of know something what I'm going to talk about. It is not a boring topic. Unfortunately, whether you like it or not, you should know this. It's as simple as that. Now I know, being a trainer, how trainees are really nailed to do their log entries and how we are going to reflect. This is going to continue. So please don't think that after you've done your GP training, everything is done and dusted with the learning logs, no more e-portfolios. This has to continue for the appraisal. There is no kind of a gap in it. Now, these are all is theory, okay? I'm just going to give you some practical tips, what to know, how to do it, which will be useful for you. Now, just to pick your brains on it, I don't want to keep on talking. It's a boring thing, one-to-one. So I just wanted to know, I knew that few of you are ST3s, one has been qualified new. I'm more than happy to take questions as we go along. So you can kind of, stop me whenever you like. Now, just wanted to know what is your finished exam, and you're going to finish exam, pass exams. So I just wanted to know, what is your understanding about appraisal? I don't want to just talk without kind of knowing what your background is. Huh?
We all have.
Oh, okay. Okay, many congratulations then. Okay, welcome to the GP world, real GP world. So what is your understanding about appraisal? Have you heard? You must have heard about the word appraisal.
Doing it a lot of times when I was ST1. So I
Yes.
know people come in, GPs come in.
Yes.
To go to another trainer who is does appraisal.
Yes, yeah,
Same as we do a portfolio, they prepare everything.
yes. How much you're responsible, how much is the appraiser responsible? What do they do in the room? Have you ever thought about it? When appraisal happens, what are we doing there? Any idea?
Just like PDPs and discussing how you have education supervisor, not that strict, but in a similar way,
Yes.
having a feedback. And
Yes, but that is the difference. It's not a trainer-trainee. It is a professional discussion among two professionals, because you have all become a GP. No longer we are going to police you whether you have done or not. The difference is it is just a formative assessment, not a summative assessment. Whereas as a trainee, I'm going to say that whether you would be, hopefully will be passing or failing, and I have a different eye. But whereas an appraiser, I'm just helping you through the professional discussion to set up your goals, as you rightly said, for the PDPs, and reviewing your past performance. So how have you done so far, what it is. So we are not there to say it is right or wrong. You understand? That is the difference you should understand between the training and the appraisal. Okay? So am I clear on that? So what it means is, you have to still evidence all your kind of work, what you do during that past year. You can't escape from that. So what appraisal does is, they are going to say, all the 5 years, whether you are ready for revalidation. You know what revalidation is? Yeah, so kind of you must have heard. So what it means is that you're licensed to practice fine after 5 years you have shown enough evidence to the GMC. That's what the revalidation in nutshell. Now revalidation is a summative process for that matter. It would say pass or fail in a way to say that all evidence is there, all evidence is not there. Okay, so that is the difference between the appraisal and revalidation. Now whatever, please read that. So revalidation supports you to develop your practice, drives improvements, and give your patient confidence that you're up to date. That's all. You're telling GMC and your patients that you're safe to practice and you're having your proper kind of CPDs done. Okay? Right, it's a lifelong learning for doctors, you know that, and it is a 5-year cycle. Now, as you have in your e-portfolio, why I'm comparing to the e-portfolio is because you're all newly qualified GPs or going to be newly qualified GPs, so I'm just relating in that way. So I'm not underestimating you guys, okay? So please don't take it otherwise. So how you have got e-portfolios where you write your log entries, what you went well, what did not go well, what will you do, exactly the same thing happens as a GP for us as well. So what we do is we divide that into 4 columns. So what you knowledge, skills, and performance. What you do here is, how are you going to demonstrate to us that you're having a continuous professional development for that? That's all. It's called CPD, okay, for the first one. Safety and quality, QIAs, quality improvement activity, case reviews, audits, which I'll go through later on. Third one is communication, partnership, teamwork, where you do your PSQs and MSF. Like that, you should have once for every revalidation cycle. Yeah, say for example, you're revalidating in 2019. If you have done it in 2015, still it's okay. If you have done it in 2016, still it's okay. Unlike you guys that you have to do it quite often. Yeah, okay. Maintaining trust, of course, it's all probity issues and things. Am I clear so far? Tell me if I'm fast or slow or yes, or boring, I can stop as well. Yeah, right. Okay. So 50 CPD hours. Now, what is 50 CPD hours means is, say for instance, you do so much in a year. Yeah. So what it means, like you can do consultation, you must have read about asthma, you must have taught someone, whatever it is, but you can't put everything in the e-portfolio like your trainees kind of thing. So we want 50 hours of quality evidence, but that doesn't stop you from fitting 100 or 200 or 150, but depends what quality of evidence your appraiser is going to take. But minimum 50 CPD points in a year. Is that clear? Because this is an opportunity for you guys to discuss it with your trainers when you're finishing, when you're going to get your CCT, to tell me about appraisal and have some PDP plans, yeah, to follow through for your next year, so that when I'm most of us, when we are appraising, we have a little bit of a problem with the newly qualified GPs not understanding the process of appraisal. They just come there not prepared. They are thinking what is going to happen. So we are not there to babysit any, because you're a newly qualified GP, you have to get on and know things, how it is going to have a smooth process. So please take this opportunity to discuss with your trainers and understand this, because nobody will be there after you become a GP. You're in no man's land. Nobody will come and tell you this is what you're supposed to do. Yeah. So 50 CPD credits. Now reflections, I know people are not very happy with the reflections, and I can go on and on about the trainees' reflection on that. So what I'm going to say is a quality reflection, yeah. Still all the GPs have a problem asking how much I should reflect, how much should I not reflect after all the court cases going on. As far as if there is no incriminating evidence against you, a quality reflection is necessary. Say for instance, somebody had a, the patient you saw, everything you safety netted, still he went and jumped before the train. Yeah, whatever. You have safety netted, fantastic. I gave only 3 days of diazepam. Father was there to safety net, everything fine. But still, if that GP writes in the notes, oh, I've done everything, but still, I would go and educate myself by doing a suicide module, something like that. Now, this evidence can be going into the court of law and asking that, oh, that means you didn't prepare before for the suicide risk assessment. So the reflection should be, this was an unfortunate case. This is one of those cases which came. So I'll be more kind of vigilant, but not telling I'll go and do the module. So you're reflecting properly. It is not that something that tomorrow it should be anything against you. Okay, this is off books, but what I'm saying is reflection is important. No appraiser will be all hot on. If you're going to give, I went to this CPD conference, I had asthma of 4 points. I went to GP update, I had some 8 hours of CPD. We are not interested. We want reflection on those teaching, whatever you had. You understand? So please don't get all the certificates. We are not interested. Okay, so it's very important that you have some reflection on those learning points. QIAs, they were a little bit hot before that. Every year they wanted whatever audit or significant events, but not necessarily audit is not compulsory anymore. I know trainees are not happy with audit, but if you go into a good practice, if you're a good clinician, audit is the only way you're going to learn. It's entirely up to each individual. Okay, so good case reviews, good CPDs, good kind of audit, medicine management, go into different meetings, so that is all important. Everything can be considered as a QIA. Okay. I'm not going to talk about all MSF and PSQs. It's a routine thing. There is a lot of things where you can go and do your PSQs through Clarity. I'll tell you about the toolkit where you can do. It's slightly different from the RCGP toolkit. Okay. Complaints, compliments, significant events. It's a probity issue. If there is a complaint against you, you have to declare it. Yeah, it's not like a hiding under the drawer, I didn't have any complaints. Even if it is a verbal complaint, if it is against you, if there is any record in the practice, please do say this is a verbal complaint, I reflected on it and the complaint is resolved. So it is very important, again written complaints. And even if it is a complaint against that you are under PAG review or you are under GMC, you have to declare that. So it's slightly different from the trainee e-portfolio. Compliments, of course, it's always nice to have. Doesn't mean you have to upload 50 thank you cards. We are not interested. Whatever you say, had a good compliment, I'm positive about it. Yeah, so how you reflect against it. Significant event, well, all this near miss, what is the difference between near miss and significant event? There is lot of kind of, what do you say, the difference in the GMC. So, so you have to know significant event is not necessarily something really big harm has happened. Before they were telling even if you missed a referral, that can become a significant event, but not necessarily you should include those unless it is really significant. You missed a case, the patient did not have a 2-week wait referral, the patient contacted you and that case turned out to be a cancer. That becomes a significant, not just because I missed a referral, don't kind of clog your toolkit like that. Yeah, so significant event should be having some significance to it. Yeah. Yes, now you have all used RCGP toolkit, yeah, for your training thing. So we have different forms of toolkit. One which is, I'm not a representation of that company, okay? So I'm not representing any company. So one of the thing, it is quite popular among the GP is something called Clarity Toolkit. Unfortunately, we have to pay for it for an annual subscription, yeah? The only thing is maybe you get a tax rebate out of it, only advantage. But it is a very user-friendly toolkit and it is very easy if you have already used the RCGP kind of combined with Clarity actually. Before when I joined, I was just doing an RCGP thing. So, but then I switched to Clarity because they both amalgamated together. So that is called Clarity Toolkit. Clarity Appraisal Toolkit. There are other toolkits like 14 Fish, GP Tools, MAG Forms, etc., etc. But all others, in my opinion, is complicated. That is my personal opinion, but that shouldn't stop you from going and Googling it, what is user friendly for you. But Clarity, I know there is an annual subscription you have to pay, but it is very, very user friendly. Anybody can use it, yeah? Right, okay, now say for example, in a GP, trainees are different, isn't it? We just go see case and you don't have any roles apart from being a trainee. But when you become a GP, you kind of go and develop your interest in different things. So say you might be interested in minor surgery, you want to become a dermatologist, somebody would say women's health, somebody would want to become an educator, a trainer, somebody want to become an appraiser, yeah? You know, you should all go and just do some homework about CCG work, you know, what is LMC works, and that's why you should go around and see what opportunities are there. Why I'm saying is, whatever you do, it has to be documented in the toolkit, which means you have to justify your role apart from being a GP. If I'm a GP trainer, I can't just put I'm a GP trainer. So I have to justify how I am developing as a GP trainer. So I have to show them I'm going to meetings. Another thing why I'm justifying as appraisal, like presenting to you guys. Tomorrow I will say I presented in GP career fair and this was the feedback I got. So these are the important bits. Like say minor surgery, you're the lead of something, MSK lead in a CCG. You have to go justify your role. Dr. Amit is he is a TPD in that area. So he has to say how he has developed. Has he gone to TPD conferences? How he is updating his role. So that is very important, A, to declare. You might be a lifeboat doctor somewhere, yes, a lifeboat doctor, something like that. You might be somewhere like a horse thing that you are the medical director of that. Still, you have to declare that role. Not only from the doctors and the allied professional, you have to do the other roles as well. Even if I'm a teacher going to do something else, I have to declare that. If I'm a privately doing some examiner role somewhere, I have to declare that. So that is what it means, yeah. Minor surgery is the same thing, trainer, hospital work, private, ship doctor, cosmetic work, yeah, everything should be thing. Appraiser, if you're, that's another thing I wanted to talk. You can take this opportunity to go and come and discuss if you have any personal questions. If you're interested in becoming an appraiser, start doing the homework now. So what is needed? What is the skills needed to become the appraiser? What is the process? This is another role for you to become an appraiser. So that's what I'm saying. So I took appraiser because I thought it's an extension of my training job. So it is just when you start something, then you build up on that. So if you do dermatology, you've done Himanshi, you can think, okay, how can I become a cosmetology? I want to do 1 or 2 sessions of doing some Botox injection, get some money. But how are you going to justify that role and what development you have got? So that is very important. So you can see, usually you are with an appraiser for 3 years, okay, provided mutually you like each other. If you don't like that appraiser, you can still declare it to say that I'm not very comfortable, but the normal cycle is, what happens is the appraiser no longer, before we used to have a personal kind of, oh, can I have my friend, I'll have Amit as my appraiser and he'll have me and that's all done, yeah. Now it is a very formalized, structured process where the NHS area team would allocate the appraiser. See, once you're done, you have informed that you are on the performance list, you're doing the GP work, you should inform the area team to say that your role has changed from a trainee GP to a proper GP. Then they will say, they will send you the emails, who will be your appraiser. The next year you have to contact, so the appraiser will contact you. So the normal appraiser you'll have for 3 years. And then what it is, we have to review your documents. As the trainer review your documents, ideally we need 2 weeks to review your documents so that we prepare for your appraisal. Yeah, okay. Same thing what we do, what happens in the appraisal discussion is, we'll go through what you did for 1 year. It's not like a trainee, okay, tell me about your consultation, what happened. It's about what was your role, how did you progress, you became a locum to salaried or salaried to partner, and that appraiser will give you some ideas. The role of appraiser is to signpost you, that's all. They are not telling you should do this or do that. We don't have any role in it. We'll signpost, okay, you thought about dermatology, why can't you just go subspecialize something? Did you think about it? Are you interested in training? So we signpost you and help you to develop, okay? And we'll give you a PDP. Say for instance, you want to do from trainer to something, I'll say, did you know there was a trainer course there? Do you want to do that? And that becomes your PDP. So according to you, it will be tailored to the GP needs. That's what we do. It's a professional discussion. I learned many things from my appraisees. So it's like a mutual, provided the appraisee is okay, yeah? So it's a mutual kind of a discussion what we have between those two, yeah? Of course, challenges, we talk about their challenges, and I always say appraisal is a very confidential thing. So people come and talk about their partnership issues, their family issues, not family in the sense, not too much, but how it affects the work. So they talk about their aspirations, their challenges. So it is a very, not a personal thing, it's a very professional one where you have to be very neutral, kind of understand it and signpost them. So that is the role, and the most important role of appraisers to make sure that you're ready for revalidation. See, for example, you have not had your BLS, like Dr. Tiwari was telling, you didn't have the level 3 safeguarding. I would say this should be your proper PDP or informal or formal PDP so that you get ready for revalidation. Does that make sense? So that is the role of appraiser here. So that's what it's written, and repeat the cycle the following year, third year, and then you will allocate it to the next appraiser for the forthcoming ones. Yeah.
Okay, so yeah, so moving on from Sunita, as long as you've had 5 pretty good appraisals in the year and everything was happy, you'll be signed off by a responsible officer. At the moment, that's Alistair Lip, who sits in Swift House. It's a fairly straightforward process as long as you have everything. In your last appraisal, before your revalidation, your appraiser will know that you're being revalidated next year, and they'll just go through a checklist of things that you should have. Where people normally fall down, MSF's not done, PSQ's not done, child safeguarding level 3 not done, or an up-to-date BLS, okay? You can't be revalidated without all of those being in date. And hopefully you'll get, the year before, you'll be told you need this for revalidation. If you haven't got it the month before, you'll be told again. You do have a little bit of a gap to get those done and submitted. If not, your revalidation is moved forward by 90 days, 120 days, up to a year. You can carry on practicing, but you're under a bit of strain to get on with it and get revalidated. If that happens 2 or 3 times, then you're in trouble and you'll get a letter from the GMC saying you're not engaging in the appraisal process. We're getting slightly concerned. We have had our first GP asked to stop working for non-engagement recently, so it can be a real problem, okay? I probably should, I'm not being sexist here, but for people who go on maternity leave, appraisal actually stops the moment you go on maternity leave. When you come back after a year, you don't have to have an appraisal if you haven't done any work in that year. You'll normally be given an extension of about 3 months to restart the process, do some learning, do some CPD, and then that all resets again. You can be successfully revalidated without 5 full cycles if you have valid reasons such as maternity leave, but it does mean that you do still need an MSF, a PSQ, and all the other important bits, but you can be revalidated on 3 years or 4 years of evidence. They will look at that a little bit more closely for you, if that's the case. Prorated,
so
absolutely.
If you come back for 3 months, they will not expect 50 CPD credits, so that will be prorated. So whoever is planning can go ahead. So it is, yeah.
So it's a fairly mundane process. You'll get an email from the GMC saying you have been revalidated after all the checks have been done, and then you repeat the whole process over the 5-year cycle. So resources of information, there's loads out there. I would recommend these are the only ones you read when you qualify. If you're in your ST3 year, the best one to read is this. So maybe put it down as one of your PDP items for your ST3 and say, I've read the RCGP Mythbusters. And it does tell you, it gives you a lot of information, and it tells you a lot of stuff that people will tell you which is completely wrong, such as you have to reflect on every single piece of information. You need 50 hours of this, that, and the other. It's all very clear. It's a very good reading material. The other 2 are slightly long-winded documents, but they're the official NHS ones. But I would stick to this. So stick it on as a PDP for now, especially if you're about to finish. Finish it and then talk to your trainer about it. It's quite a useful document. Questions about any of the above?
After finishing,
Mm-hmm.
you have to have your first.
Okay, so when you finish your PCSE forms and you go on the performers list, your name will pop up in the management team. Normally when you're getting to the end of your first year of qualification, you'll be given a month. So it'll be either somewhere between 9 and 12 months after you're fully qualified and you're on the register, okay? They don't generally tend to do appraisals in March moving forward, and you'll be given plenty of notice. there's automatically generated emails that go to you and your appraiser saying your appraisal is due, please have it done by this date, and then you can just get on and do that.
My revalidation due.
Yeah. So
And
you're
this year?
you're a trainee, yeah? So as soon as you finish, you will be revalidated, okay? And so the clock resets, okay? As HE sort all of that out for you before you start, before you finish training. After you finish training, it's down to you to make sure you keep up to date and do it all yourself.
The area where you are, isn't it? Say for
Yes? Yep. Okay. So if you want to defer appraisal, or if you're not working as a GP, you can fill in a deferral form. Okay. They're all looked at individually. If you're going on maternity leave and stuff, you have to do it to tell them that you're not working, so everything moves forward. If you're going abroad for 6 months, or if you're just taking some time out to look after family or any other reason, you can fill in a deferral form, and as long as the reasons are valid, it's not a problem. Everything just moves forward 6 months.
GP with special interest or something, does that make any difference?
It makes no difference whatsoever. The only difference is that you have to show the appraisal team that you're keeping up to date, and you're fit to practice in the roles you're suggesting, okay? So if you're a dermatology gypsy, it would be expected over the 5-year cycle that you'll show you've been to dermatology courses, you've updated your minor surgery skills, so you need to show that you're up to date. But no, it doesn't make a difference. You will still, your appraiser will still look at all your roles that you do. I have 5 roles. My appraiser hates me, but I try and break it down into, look, for my GP role, these are the bits I've done. For my TPD role, this is the bits I've done. For my appraiser role, these are the things I've done. And then she can see, look, actually, he's done a little bit every year for everything, and that's fine. Okay? Most people just do 1 or 2 roles, and it's fairly straightforward. So your appraisal area is where you do the majority of your work. It doesn't matter where you live, okay? So if you live in London, but all your work is done in Essex, your appraisal team is the Essex area team, okay? If you work in both, it's where you do the majority of your work, okay? So, for example, if you're a salary doing 6 sessions in Chelmsford and you just do 1 or 2 out of hours in Romford, your appraisal area is still Essex.
Do we have a choice?
You don't have a choice. It's where you do the majority of your work.
Say if the ratio is changing
Yep.
over time,
Yep.
you have to inform.
You do have to inform and let them know. So when we do our appraisal write-up, the first thing we write is, this is Dr. X. He does 6 sessions in this place and he does 2 sessions in that place. So that'll be picked up quite quickly. And if that's picked up, you'll be asked, well, you won't be asked to change. The area teams will talk to each other and say, actually, he's your appraisee. Could you please just take over? And it'll just, some forms are done and things are forwarded on. Does anybody want to ask what the difference is between the GMC, license to practice, and the NHSE performers list? No? Okay. So the GMC give you your license to practice as a doctor, okay? Being on the performers list confirms your fitness to practice as a doctor. They're totally different. And we get this question a lot because people are referred to the GMC, and the GMC look at their case and close it and say, there's not much to answer here. And then NHSE writes to them and says, we've had a complaint about you. Could you tell us some more information? They're like, but the GMC have closed it, okay? So the GMC only give you your license. Your fitness to practice is based on your being on the performers list, which is managed by NHS England. So you do have to prove to them or work with them to show that you are able to practice sensibly as a GP and safely. No. So if you're in a hospital job doing emergency medicine as a GP, you're doing it as a GP, not as a specialist. Okay. So because you're still a GP, your appraisal will be with them. The only caveat there is if you do 8 sessions as a GP in A&E and no GP sessions, that's when it becomes a problem. Okay.
Because you haven't met the requirement of 1 or
Exactly, yeah, okay. And eventually what will happen is you'll probably be removed from the GP performers list, and your RO, your responsible officer, will become the responsible officer for the hospital team, and they will take over all of that side of things. Okay? Any more?
Yeah.
Okay, we're around for a bit if you want to come and talk about anything else. Hope that was useful, and good luck with your careers.